mostly we'll be focusing on state legislation. We'll also be discussing a piece of regulation in the state of New York that I'll touch on in a minute. But broadly, we divide the legislative pieces into three categories. So they're imperfect categories, but we look at them basically as addressing transparency, cost-sharing mandates, and things that affect the supply and demand curve for pharmaceuticals. And there's a lot of legislation in this space. A lot of it fits into multiple areas there. So something that's a transparency piece could also address cost sharing. That's typical in the larger PBM reform packages, for example. On the transparency side, we see a lot of reporting requirements for PBMs and health plans. And this is, when we talk about transparency, I think most people go to transparency for the patient. But most of these proposals are really transparency to the state. So it takes an approach similar to what we've seen at the federal level with the FTC's involvement in PBMs, where it's really focusing on PBM trade practices rather than the clinical side of things. And so these are requirements to do something like reporting cost-sharing increases or premium increases. We're looking at prescription drug affordability boards, which have impacts on all three areas. There are 7 states that have PDABs currently, and there's another 10 states that have introduced legislation to create those boards in 2023. So I think that's a big piece of this. On the cost-sharing side of things, we're seeing a lot of states that are interested in copay caps, for example. The insulin example is a great one, where states are capping it at about $35 for a month's supply. And then things like altering the supply and demand curve. This could be importation. No state has implemented it, but there are lots of states that are exploring it. So those are the major legislative pieces. On the regulatory front, we will be discussing in pretty good detail the large PBM reform regulation that's going in New York State right now. And the reason we're spending so much time on that one is because we think it's a model that other states will emulate. New York and California in particular tend to be states that other states follow in that regard. And so it's a really sweeping package. It does a lot of the things that we talked about on the legislative front, examining the business practices of PBMs and requiring various reporting elements for PBMs. So the IRA is a big piece of legislation. From the AMCP perspective, we're really focused on 2 provisions of the IRA in the prescription drug portion. We're looking at the drug price negotiation piece for Medicare and then the out-of-pocket smoothing piece, which is, I think, probably the one that has more questions that need to be answered than negotiation. Negotiation is pretty straightforward when you get down to it. We know what the drugs are. We know how the negotiation will be conducted. The question mark that exists around the negotiation piece are the lawsuits that have been filed by the manufacturing community, which could, in theory, completely repeal that portion of the Inflation Reduction Act. I don't know if that's likely per se, but it's certainly on the table. And so if the court decides that that portion of the law is unconstitutional, it'll come out. But that's the only real question on the negotiation side. On the out-of-pocket smoothing, that's a much bigger question because it's a completely new program for this country. No one is doing this right now, and basically what it requires is Medicare beneficiaries they are going to be able to opt in to a program that allows them to distribute their monthly payments or their out-of-pocket maximum across however many months remain in the year. So if you opt in January and you're on a very high cost prescription and you hit your $2,000 out-of-pocket maximum, that's the new out-of-pocket maximum established by the IRA, you can enroll in this program that will allow you to divide that $2,000 payment up into 12 monthly installments of about $167. The other piece of that is that you have to be able to enroll at any time. And so if the patient could choose to enroll in July, in which case they would divide it up over the remainder of the year. And that's just a huge challenge. No one is doing that. It's going to be a large burden on retail and community pharmacists who will be the patient's point of contact for most of this. There's a requirement that this just happens, at the point of sale, so the patient doesn't need to pay the $2,000 and then they get reimbursed or something like that. They only pay, whatever the monthly maximum is under their smoothing arrangement. And so that's going to be very confusing for a lot of people. It raises questions about how will a Part D plan react if a patient changes their plan, or they are unable to pay the rest of their prescription cost under a smoothing arrangement. And there hasn't been a ton of guidance from CMS on this. They released their initial guidance in September of 2023, and it's a good first step, but there are a lot of questions that remain to be answered. So hopefully we'll get some more clarity from that soon, and we'll be able to have a clearer picture on what exactly the smoothing program will look like when it's operationalized.